Good morning, good afternoon, good evening, wherever you are. Welcome to Virtual Grand Rounds. Premier Education brought to you at no cost thanks to our sponsors, AstraZeneca, Medtronic, and Medela, the Science of Care. I'm Eric Lim, your host for today, and it's a great delight for me to present Professor Heather Wakelee, who is the Professor of Medicine and Chief of Division of Oncology at Stanford University. Many of you will already know Professor Wakelee from her work leading the trials both across immuno-oncology as well as advanced lung cancer. And today, Professor Wakelee is going to talk to us about the multi-modality immunotherapy regimens for resectable lung cancer. Heather, over to you.
Great, thank you, and thanks for that kind introduction and for inviting me to be here today. So I'm going to be talking about multimodality immunotherapy regimens in resectable lung cancer, and I understand the audience consists of many surgeons and also some medical oncologists and others. All right, this is my declaration of interest. So when we think about this, we have the preoperative or prior to surgery neoadjuvant immune checkpoint inhibitor studies, the postoperative or adjuvant immune checkpoint inhibitor studies, and the perioperative where you kind of do both. Some people have talked about it as the sandwich approach. And again, ICI immune checkpoint inhibitors. So we only have one trial so far that is just the pure neoadjuvant. That's a randomized phase 3 study. I didn't put the study schemas, but you can imagine this involves giving chemotherapy and immunotherapy and then surgery, and that's it. And that's the Checkmate 816 trial. We've just seen the 5-year outcomes presented at ASCO in 2025 by Patrick Ford. A lot on this slide, but walking you through it. Event-free survival, we see 49% versus 34% of patients living without active cancer at that 5-year mark and not having had an event that would have prevented them from being treated definitively with surgery. When we look at overall survival, they actually hit a definitive outcome. 10% difference in overall survival, hazard ratio of 0.72. And we kind of dig into the details. This was seen in both stage 2 as well as stage 3. However, the PD-L1 level was really important, and patients whose tumors did not have PD-L1 really did not seem to benefit particularly from this approach of the neoadjuvant. This is a little bit more detail showing that patients that did have a complete pathological response did quite well, though not without risk of some recurrences. So some of these patients did recur. I will point out that only 4 patients on the chemotherapy alone arm had that path CR, many more, over 40 on the nivolumab and chemo. So keep that in mind as you look at this. Patients who did not have a complete response, many more had recurrences, and yet there was still that plateau where a third of patients who'd not had a complete pathological response still doing well at that 5-year mark. We also looked at ctDNA clearance, which remains very prognostic. All right, that was neoadjuvant. Key points, only 3 cycles. Everybody got immune therapy. PD-L1 is important. Driver mutations. So if there was a known driver mutation, those patients were excluded. And more in stage 3, but also in stage 2. And now we've seen overall survival benefit. So what about pure adjuvant? What about if patients go to surgery first and then get additional treatment? These were usually chemo followed by immune therapy. The trials were designed before we knew that combining them was a good thing. The trials combining chemo and immune therapy are now either ongoing or being considered. But keep in mind that this approach is different from that perspective. It wasn't given together. Okay, we have 3 trials here. Again, I'm not showing the schema. They all have the same schema, surgery, and then chemo, and then immune therapy, with that randomization about the immune therapy, some subtle differences, but let's focus on that big picture idea. With the Empower O&O trial with adjuvant atezolizumab, when we look at the subset of patients who had some PD-L1 expression, stage 2 to 3A, 5-year follow-up, we're again seeing that there is, in this case, disease-free survival benefit, hazard ratio of 0.7, that nice separation of the curves. When we look at overall survival, We can't talk about that difference statistically, but we're seeing that similar kind of range of a difference where you still have an overall survival, again, not statistically true. The other adjuvant trials have been more confusing. The Keynote 091, clear benefit in disease-free survival. However, PD-L1 levels not mattering mattered a lot for Empower 010. And then the BR31 trial was a totally negative adjuvant trial, otherwise designed the same. And so that gets everyone sort of confused about what is adjuvant really doing. So adjuvant, everyone gets surgery. I know many in this audience will think that's a big plus. Driver mutations are known for all patients, of course. You can really try to figure out additional treatment based on whether there's a path CR or, like what you saw. Of course, you haven't given any kind of treatment ahead of time. So what does that tumor look like under the microscope? And what we'd like to be able to do is think about who maybe is truly cured with surgery and doesn't need additional adjuvant treatment, but our MRD or ctDNA, we'll talk about that more later. It hasn't gotten to that sensitivity yet. And PD-L1 results are very confusing. Okay, now we have perioperative, the sandwich, pre and post, 5 trials. When we look at the event-free survival from these trials, it's all been very, very, very similar. We are seeing these event-free survival hazard ratios of around 0.68, some a little bit different than that, but very similar curves, very similar outcomes. I didn't show all of them. Neotorch and Rational 315 similar. But we've only seen overall survival from this one trial. This is the Keynote 671. And there we see a nice strong separation. That overall survival hazard ratio, 0.73. All right, so kind of wrapping yourself around all of this, we now have positive with neoadjuvant for overall survival. We have a positive trial with perioperative. And with adjuvant, it's a little bit confusing with trends that looked great, but nothing we could say definitively. With Keynote 671, again, that PD-L1 level is really important. Not quite as important within Empower 010. When you look at the patients with less than 1%, though, overall survival, a little questionable. And then some of the EGFR mutation stuff is very confusing. I'm not going to have time to go into all that today, though. Biggest issue to talk about with neoadjuvant and perioperative, about 20% of patients never make it to surgery. Just like for those who get to surgery first, not everybody ends up getting the systemic treatment. Okay, so perioperative, we've had 5 trials, definite event-free survival benefit, overall survival now proven in Keynote 671. PD-L1 levels are really important in all of the trials. If there's a driver mutation, most of the time they've been excluded. And stage benefit across stages, at least stage 2 and 3. But you have increased toxicity when you do this perioperative, increased costs, more therapy, and about 20% no risk, never get to surgery. So that's a big risk. So there's some key remaining questions. Who should go to surgery first? What does the adjuvant component add to the neoadjuvant? What is that optimal duration of immune checkpoint inhibitors or adjuvant targeted therapy? How does ctDNA help us? And what are some future steps? So who should go to surgery first? Probably most stage 1, if not all. Which stage 2 patients? There definitely are some where that surgery is that most important component and they should go first. And how do we determine who is at most risk of not getting surgery if systemic therapy started first, right? These are kind of the big questions that we need to ask. So what does the adjuvant immune checkpoint inhibitor component add in neoadjuvant? We don't really know. We need trials still to answer that question. They're being designed within the US cooperative groups and actually getting started. They're being done in Asia. This is really critical. There was an analysis taking the Checkmate 816 neoadjuvant trial versus the Checkmate 77T, which was a perioperative study, both with nivolumab, trying to match patients and come to an answer on this. However, it was a bit flawed because the Checkmate 816, they looked at patients who got to surgery. On the Checkmate 77T, it was patients who got to surgery and got some adjuvant treatment. And so you end up comparing a different group of patients to each other. We know that patients who get neoadjuvant get surgery and then don't get adjuvant if they were supposed to, something happened where they're just not fit enough for it, so they're not such a good group of patients. And I've got a little bit more on that. So this is the analysis that was presented at World Lung last year by Patrick Ford. 816, again, people got their neoadjuvant, they got their surgery, but then either checkmate 816, all comers who'd gotten a surgery, or 770, only those who also got adjuvant. These results looked okay, but you're really not comparing the same group of patients to each other. And I'm switching to a different trial here. This is Keynote 671. I'm showing this poster that Marina Garcino presented at ESMO in 2024, just to show this is in the darker color. These are the patients who got their neoadjuvant treatment, got their surgery, and got adjuvant, whichever arm they were on, versus those who got to the surgery and then didn't get adjuvant. And you can see this is a group who didn't do well. So if you take this group out of your analysis, you're obviously going to have a bias. So I just go through all of that to say, don't read the headline from that analysis and think that it tells us we need that adjuvant piece. We haven't answered the question, and we need to keep looking at that. Okay, so what is the optimal duration of treatment? We don't know. I just put a couple of comments there. We're not sure, even in metastatic disease, whether or not patients should get, like, what duration of treatment. Should it be 2 years? Should it be more? Should it be less? So we really don't know in early stages. And maybe ctDNA will help us. So how does ctDNA help? I think you're all very familiar with using ctDNA in a lot of different aspects of lung cancer therapy. But for MRD detection, which is really trying to figure out, after the tumor has been completely resected or treated with definitive radiation, how do we know if there's still some lurking cancer ready to come back? Is there a way to test for that? And that's that MRD testing. What I'm showing on this slide are some of the earliest work from a couple of different groups. One at Stanford with Max Dean and Asha Lizaday. Obviously, I know their work quite well, worked very closely with them. This was a cancer discovery paper in 2017 showing if we didn't see MRD, patients did well. And if we did see it, they recurred very quickly. Around the same time, of course, in the UK, great work being done by Charlie Swanton and his team, very similar outcomes. And so these two and then many other groups are trying to develop this MRD testing. We have a trial at Stanford now using that technology for patients who had early stage disease, like stage 1, either had surgery or stereotactic radiation. We did the ctDNA for MRD. If it's negative, we watch them. But if it's positive, we then are giving them additional immune therapy and then seeing how that works. So these are the kind of trials we need to be doing to determine if MRD is really going to make a difference for us. And what are future steps? We need better drugs. We need to figure out the contribution of components, and there's just a lot more work to do. So all of these options are good. Neoadjuvant, adjuvant, or perioperative, depending on the right patient. We do need to test for EGFR, for ALK, and other driver mutations. We need to know PD-L1 levels. We need to stage and ideally multidisciplinary tumor board discussions. We do have adjuvant targeted therapies for patients with tumors with the right driver mutations. I think in stage 3, neoadjuvant or perioperative immune checkpoint inhibitor with chemo is a standard of care. Unless it's patient who's not going to get surgery, and then we need to go in with our definitive chemo radiation. For stage 1 and 2, it's more controversial. I do think surgery should go first for some of these patients. More work is needed on biomarkers of response and comparative trials. We need to determine if that additional adjuvant treatment really makes a difference after neoadjuvant. ctDNA, I think, is going to be critical for optimal management once we get the MRD test sensitive enough. I don't think the commercial assays are ready for that yet. We need better, newer drugs. And we have a lot of other questions to help us figure out who should go to surgery first, who needs that neoadjuvant component first, and just lots of exciting questions, and it's exciting times. And with that, I'm going to stop sharing my screen. So thank you.
Excellent. Thank you so much, Heather, for an amazing overview of what is a very challenging and complex area at the moment. Can I ask your opinion with regards to neoadjuvant versus perioperative? Because at the moment, I think very few centers are favoring an adjuvant, a pure adjuvant approach. So the current discussions around the world are neoadjuvant or perioperative.
Mm-hmm.
Given the results presented at ASCO this year, the overall survival seems to be comparable if you give only upfront neoadjuvant treatment and with that of the perioperative studies. So in clinical practice, what do you do in Stanford?
So I think that's a really critical question, and I think we have to be careful because remember we're looking at 5-year data now from Checkmate 816. We haven't yet seen 5-year data from any of the perioperative trials, so we really can't say that the survival is really equivalent or similar. I mean, it might be. It's trending in that direction, right? But I think we have to be careful. 5 years is such an important landmark, of course, because that's always been what we've considered as the time of cure. Now, is that shifted a little later? If you're giving all of this immune checkpoint inhibitors, we don't know. But I think we do need to probably wait until we see the 5-year data from some of the perioperative trials to be sure that we can really say that. I agree with you, though, that, it was really exciting to see the Checkmate 816, wonderful to see that survival data. We have to keep in mind event-free survival. More than half the patients, pretty much half the patient, was 49%, had recurred, had something happen where they, event-free survival. So we still got that 50% not making it. Survival better than that, of course, because we have so many great systemic treatments if someone does recur or localized therapy. But I don't think, we've settled the question that that's all we need to do if you still have more than half of the patients having an event or already dying of their disease, right? Are the 5-year outcomes from the perioperative trials going to be better than that? We don't know yet. Some are trending, but some of them are probably not trending that way. And we just need to kind of wait and see. And we need to figure out, I think that what Checkmate 816 has shown us is that if you have a pathological complete response, most of those patients are doing well, and maybe they don't need that additional treatment. But for patients who don't have that pathological complete response, we need to do more. And is continuing the same adjuvant checkpoint inhibitor really making a difference or not? Well, we're trying to figure that out with our Stanford trial that I showed you on that, second to last study using the MRD testing in earliest stages of disease. There are others kind of trying to answer that question that way also. If you look at how do we answer that question, I did spend a bit of my talk here ruling out that like comparison between 77T and 816. It was a good attempt, but I think the way it was presented didn't really give us an answer to that question. Maybe they can redo it and try to see if adding that adjuvant helps or where it might help. I think for patients that do have positive minimal residual disease, ctDNA analysis showing that it's still there, we need to escalate in some way. And maybe it's continuing with checkpoint inhibitor. Maybe it's doing something else. Maybe there's nothing that we're able to do yet with the treatments that we have. But I think there's enough questions left that I really don't think we can just say, oh, Checkmate 816 has answered the question. So.
Sure. So from your answer, I infer that you're going for perioperative regimens more routinely in your clinical practice.
We are, but we are always talking with the patient. I think that I haven't actually had a newly diagnosed patient to talk to since 816, since ASCO. It's only been a couple weeks. I've had my thymic carcinoma patients have been coming in more recently as my news. So I think that for the next one who comes in, certainly, we'll talk about this and say it's possible that you only need 3 cycles of chemotherapy and an immune checkpoint inhibitor. But we haven't, definitively solved that. And, I think it's reasonable to go with those 3 cycles, go to surgery. And then if there's a great pathological response, I'm much more comfortable saying we're done. But if there isn't, not sure that I'm going to be, comfortable saying that. And so then you just come in saying we're going to do a 7-7T regimen with that perioperative nivolumab. Or do you say, we've got this overall survival data with Keynote 671, and we should just start with pembrolizumab with the chemotherapy and then, plan to continue that. And I think that's where we struggle because then when we're in different healthcare systems around the world, there's obviously different reimbursement as well and different criteria necessary to be able to think about which regimen you might give to each patient. In the US, we tend to have a little bit more flexibility. As soon as something is approved, we can sort of use it. We don't have the same strict guidelines for better or worse, right? So it's kind of a little bit different, but that doesn't mean that one is better. It's just, I have more freedom of trying to decide what to do, which maybe isn't really necessarily better for the patient, but that's where we are right now. So we kind of flex around with it. Can I ask you what you're doing, or is it a question? Not are the questions only coming to me for this, which is
No, no,
totally fine.
no. You can go bilateral. So we've conducted a systematic review and meta-analysis, and I'm going to go out on a limb because we looked at all 15 trials, and we published in the European Journal of Cancer
Mhm,
the additional benefit in terms of overall survival from our statistical modeling would be an additional 20% improvement in overall survival. If
mhm,
you compare perioperative to neoadjuvant alone. Uh,
mhm,
but the difficulty is that I think the key question is giving the justification back to the patients
mhm,
whether or not a 20% additional improvement will be worthwhile. Because in the before the immunotherapy era, we based it all on chemotherapy alone. And we know
mhm,
that chemotherapy, when we told our patients an overall improvement of 20% survival, only 50% would agree to have chemotherapy. So then
mhm,
I think, or I'm going to put myself out on a limb to say that the future question is going to be for an additional 20% benefit, how much would the patient be willing to endure for one whole year of treatment? And
right.
secondly, is how much healthcare systems would be willing to pay for the additional 20% benefit.
Mhm,
Having said that, in the United Kingdom, it's approved. So pembrolizumab has been approved for perioperative up to 1 year. And what I find also very interesting is that only 30 to 50% can actually complete the whole 1 year of treatment.
mhm,
And so the cost and how much people can complete and what the actual value to the patient is, as you said, remains in question.
mhm,
So for now, at the moment, for my multidisciplinary or my tumor board, we've decided to go for neoadjuvant, with the option of perioperative in conjunction with a number of clinical trials, which the
mhm,
oncologists are interested. Because with the perioperative regimens, some of the trials mandate pembrolizumab treatment. And as you mentioned, in Europe and in the UK, it's very strict. So if you are on preoperative or a 671 pembrolizumab regimen, we can't then change it halfway. We can't,
mhm,
and we don't have the liberty to start with nivolumab and then change the system. And I think the guidelines from the EMEA as well as NICE in the UK are based on the clinical trials
mhm,
completion from start to finish, and therefore the licensing is start to finish. And also,
mhm,
what interesting point, if you have a perioperative intent, you give the whole perioperative treatment regardless of PCR. And
mhm.
which comes a question from Paul Bass actually, which is how important is PCR to you in your clinical practice when you're making decisions about perioperative immunotherapy?
Thanks. And hi, Paul. Good question. So I think, path CR is still a relatively rare occurrence. If you think about it, it's really somewhere around 20% of patients are going to achieve that. And so it's not something I go in expecting whenever I meet with a patient. And so as we talk about it, that's probably one of the strongest data sets to sort of say, okay, maybe we don't need adjuvant in that group. And yet it's a small minority of patients. And so therefore, maybe the adjuvant is needed. Um, it's something I talk about with the patients. I have to say, I've always been and one particular patient, a case that always sticks with me is, as much as we are data driven, we also always remember those particular patients. And I had a patient who didn't actually have a path CR, but almost did. It was a really strong MPR. I think he had maybe 2 or 3% viable tumors, very limited. And he had done very well with his neoadjuvant approach. I went and gave his first adjuvant cycle, and he had a horrible autoimmune toxicity, with a lot of endocrinopathies. And he has continued to have to grapple with that now. His cancer hasn't come back. It's now been a couple of years, but he has done a lot of hormone replacements. And so the lesson from that is you never know which cycle of immune therapy is going to be the one that's going to set off a bad autoimmune response. And so as we're kind of balancing that. Now, your question was around path CR and how important that is, and I sort of went off on a tangent with it, but I think that's one of the things we need to think about is how much do we bank on that path CR, knowing that it's at most 20% of our patients? Do we set patients up with this idea of like, if you hit a path CR, then you're done, knowing that most of them won't? Or do we go into it saying, we're going to do this perioperative approach? This is what, has been proven for, some of these trials, unless if you do get that great response, we can stop. Or do we just look at Checkmate 816 and say, okay, that's great, but again, keeping in mind when you looked at those curves I showed you for path CR or not, only a third of patients who did not have a path CR were on that tail. And so I think we also have to think about that. And so it's a complex answer because I don't think there's really a clear answer to it. I do think it matters. It does tell us who's most at risk. It doesn't identify everybody though, right? Because there are some patients who don't have a path CR who are still, third of those patients still doing well. And there's some patients with path CR who aren't. And so I think in the end, we're really going to have to depend on really sensitive MRD assays even more than that path CR. That's kind of where I think we're heading. We're just not quite there.
And that brings us nicely to Dr. Addy's question about how important is ctDNA in predicting the need for continuing perioperative treatment. And that's, I think, quite relevant, especially as so many different companies using so many different testing. And I presume you'll be using Max Dean's approach. The sensitivity and specificities vary greatly. So
Yeah.
would there be a one uniform ctDNA test that would help us all, or how would we go, to address this issue?
Fantastic question, and one without an answer yet. I mean, we have to get to levels of sensitivity that, well, let me backtrack from that, but if a ctDNA test is positive, that patient is at high risk of relapse. And can we alter that by giving additional immune checkpoint inhibitors and additional treatment? We don't know. We would like to hope so, and therefore we go along with that treatment. I mean, my goodness, for patients who present with metastatic disease, we're still able to get long-term 5-year outcomes in 20% of patients, even with fully metastatic, not just MRD, but like it's positive. And so I think there is a justification for using that positive MRD to give additional treatment. The challenge that we face is that I don't think that most of our assays are sensitive enough yet to be able to comfortably say, this test was negative, you're done. Right? That's that leap of faith that we haven't achieved yet. And I think that's part of the trial that we're doing is saying, okay, we're starting with the patients who should be cured, and then saying, let's do this test. And if it's positive, we're escalating. And if it's not, we're going to do what we were going to do anyway, which is just observe you. The next phase, of course, would be then to get to a point where someone who would normally be getting additional treatment, do we trust the test enough to say that's it? And that's where a lot of really innovative work is being done to bring that sensitivity down, so that we are really truly being able to find it. But those are bespoke tests. They're very expensive, and can we afford to do that also? So there's a lot of opportunity still, and hopefully we'll get to that. This is the threshold you have to hit to be able to be used, but I don't think we're there.
Yeah, I mean, that's a fantastic answer. And what's even more interesting is that the different techniques have a different lower limit of detection. So conventional NGS has a 3% allele detection frequency. And we know that Max Dean's team can go much lower. And as you said, it's directly related to cost. And I'm wondering at some point, are we going to get so expensive and so low that it no longer becomes that clinically relevant? Because if you want to detect one molecule, I'm sure it is possible if you pay enough money. There's another question from Dr. Galicio who's asking, with regards to delays from diagnosis to actual treatment, is there any consideration where you would think that upfront surgery would be better rather than continuing with another 2 or 3 months of systemic treatment prior to surgical resection?
I think that's really one of the key questions, and one I always try to highlight. Yes, there are patients who should go to surgery first. We know that when we start with a perioperative approach or a neoadjuvant approach, 20% of those patients don't make it to surgery. And it's not just because they shouldn't have ever gone on a surgical trial that, it's because some have something happen. They have a toxicity or their tumor progressed despite the treatment. That's more common than a true toxicity issue. And so how do we determine upfront those patients where that neoadjuvant approach is really not going to help them to make sure that they get to surgery, which is still the most important component of the treatment for the majority of them. And I'm not the surgeon, I'm going to say that. So I think those are the questions we still need to get at. Like, what can we determine at the beginning to say, you're not going to respond well to this, you should get your surgery first because we can do it now? And who are the patients where they're going to do so much better if we get that whole immune response going earlier before they can get to surgery, so that that's systemically going on at the time then that the remaining tumor is removed. I don't think we have those answers yet, though there are a lot of people working on them.
Certainly a very exciting space. Thank you so much, Heather, for an amazing presentation today. Next week, we're going to have Navneet Singh, who has written some guidelines on management of stage 3 lung cancer, here with us, which remains me to thank our sponsors, AstraZeneca, Medtronic, and Medillia Science of Care. And thank you for joining us all the way from Hawaii today, Heather, and I wish you a good conference. Thank you so much.
Thank you. Thank
Bye-bye.
you very much. Bye-bye.